Subcommittee will come to order. I thought it was interesting yesterday to hear the Secretary mention that in the next 4 years he hopes everybody has devices and different things. So it's exciting to hear about that, and I think it's the future, in my opinion. Everybody has maybe a different opinion, but I think you'll wait and see. It's a big turning point. Good morning. I want to thank you to our witnesses for being here today to discuss the important issues that I'm excited about, the power of digital health data. The U.S. is spending more on health care than ever before, $5 trillion annually, but Americans across the country are still getting sicker and sicker. The U.S. has a larger share of people with chronic diseases compared to other countries, and more than twice as many Americans with obesity and diabetics. Concerningly, chronic diseases make up 8 out of 10 top causes of death for the U.S. Approximately 20% of U.S. children are obese. 30% of young adults are disqualified from the service due to obesity, and 40% of adults are obese. My first point was 20% of children are obese. While these statistics are alarming, we live in a time where Americans have access to better technology and more health information than ever before to truly be the CEO, I like this phrase, of your own health, taking more responsibility. This new technology can help patients in many ways, from encouraging healthier lifestyles and preventing chronic diseases to better managing treatments at home. For example, wearable devices provide useful health data like sleep and stress information to inform medical care and lifestyle changes. For diabetics alone, wearable can improve treatments, adherence, and reduce healthcare costs by as much as 29%, which would be great. Another technology, remote patient monitoring, which I'm excited about hearing about that, more about that, allows physicians to observe vital patient data in real time wherever the patient is located. Studies have shown that remote patient monitoring reduces the risk of hospital readmission by 76% and can lower the cost by up to $10,000 per patient. Access to health data has also helped reduce health costs for employers. In fact, 72% of employers saw a reduction in health care costs after starting an employee wellness program that promotes physical activity. Despite the potential to lower health care costs and improve outcomes, only 36% of adults are wearing devices. Seniors are 6 times less likely than the younger people are today. I hope we can address those differences, encourage more widespread use of technology that can improve health. At the cutting edge of health technology is the promise of artificial intelligence, AI, to better analyze patients' data and improve workflow for healthcare providers. With 25% of new healthcare investment focused on AI technology, 25%, we are finding new applications every day. For example, new AI technology can aid providing and documentation follow-up visits, resulting in 60% improvement in work-life balance for healthcare providers. However, as more digital health data is created and utilized within the healthcare system, we must also take care to ensure technology is accurate and patients' data is protected. That's key. I look forward to discussing these challenges and opportunities with our witnesses today. I'm encouraged to work with my colleagues to reverse chronic diseases by harnessing the power of digital health data. I'm pleased to recognize the gentleman and my good friend from Texas, Mr. Doggett, for his opening statements.
Well, thank you, Mr. Chairman, and for this hearing on innovation. I know we'll get insights, as I've already seen in the written testimony. This is certainly a topic that is close to home for me, since my hometown of Austin continues to be a tech hub that's full of innovative startups, biotech companies, and a growing presence from some of the major multinational tech companies. Across the street from my Austin office is Capital Factory, led by my friend Josh Baer, a local co-working space and accelerator program for cutting-edge technologies, bringing investors and creative entrepreneurs together. Austin's becoming a health tech leader thanks to innovative companies and collaboration with the Dell Medical School, multiple University of Texas departments, and the Army Futures Command. I applaud the innovative work that we will hear about today. It's helping to improve health care and transform the delivery system to be more effective and efficient. While we all want the latest and greatest technologies, treatments and cures for our neighbors, for our families when they're in need, we simply cannot have a conversation about innovative health care without talking about access to it. To the estimated 16 million Americans that are about to lose their access to health care and the millions more who will face increased premiums and potential hospital and physician practices that will have to close, there's not anything beautiful about the one big beautiful bill. The effort to force it through this Congress right up to July 4th presents real problems for health care. This crisis, I believe, is preventable, like so many of the health care complications that result in increased emergency visits when our neighbors have no way to access health care and are forced to wait until the very last moment to get help. Whether it's high blood pressure that leads to a heart attack or stroke, a diabetic who eventually forgoes insulin and faces amputation, or an uninsured, impoverished woman like one my own doctor daughter once treated, where undetected breast cancer until the symptoms become so severe that little can be done to help. For Texans, Medicaid is a lifeline for 3 million children, 2/3 of our nursing home patients, and nearly 1 million adults with complex disabilities. About half the babies born at the Dell Children's Hospital and half the children that are seen there are relying on Medicaid. Under the big, ugly bill, burdensome new requirements that have been rushed through this committee and the House will take effect in just a few months, and they will result in fully qualified individuals losing their access to a family physician. Deep funding cuts to safety net hospitals will result in closures, particularly in rural areas, and communities losing the one place they can receive health care. In a new analysis that I would ask unanimous consent to put in the record, Mr. Chairman, this is from the Congressional Budget Office last night, directed to the Committee on Budget. It projects the states will respond to these terrible federal funding cuts by, quote, reducing provider payment rates, reducing the scope or amount of optional services, and reducing Medicaid enrollment. For 24 million Americans receiving care because of the Affordable Care Act marketplace plans, enormous premium spikes are about to occur within the next 6 months. Unless the tax credits that were enhanced keep these plans affordable and stop the Trump sabotage provisions that are also included in the so-called Big Beautiful Bill, an estimated 8.2 million Americans, including 1.7 million of my fellow Texans, will lose their access to a physician. For these folks, the Republican objective of repealing Obamacare, which has gone through this committee over more than a decade, again and again and again, has finally been achieved. Their Obamacare is being repealed. Indeed, the price of this bill is so high, so very high, that Medicare, a program that Trump and Republicans promised to preserve, will face a $500 billion cut beginning on October 1st. Each year for the next decade, the amount of debt that is being added to our country, trillions of dollars of debt, each year every single healthcare provider that accepts Medicare will face a 4% pay cut instead of a pay increase to recognize the cost of medical practice. Each year for the next decade, that is a big cut, and it's at a time that many physicians are struggling to keep their practices open, and consolidation and private equity buyouts are diminishing care. And especially for those newly retiring Americans, the difficult task of finding a physician who will accept Medicare is sure to become even more difficult. There's great innovation occurring. We're about to hear about more of it, often with the support of taxpayer research funding. We have a responsibility to ensure that every American receives the benefit of these technologies, can access them, and to do that, we must protect their access to health care. I look forward to the discussion, but I will say and apologize in advance to you, Mr. Chairman, and to our witnesses if I'm a bit of a jack-in-the-box this morning, because the House Budget Committee is considering this very matter at the same time, And there is a meeting concerning President Trump's unconstitutional war on Iran also occurring. So Mr. Thompson will be helping on the Democratic side. But thank you very much. Or Ms. Chu. Thank you. Thank you, Mr. Chairman.
Thank you. Thank you. I will now introduce the witnesses. Dr. Kristen Holmes is the Global Head of Human Performance and Principal Scientist of WHOOP. Josh Phelps is President of Winchester Metals, Inc. Andrew, I'm going to just say Ski, is my wife's Polish name, Zengilowski, so I tried to get, that took me a long time to get that. Is the CEO and co-founder of CoachCare. Dr. Gerhart Jackie Gerhart is the Chief Medical Officer and Vice President of Clinical Informative and Epic Systems. Sabrina Corlette is a research professor and co-director at the Center on Health Insurance Reform at Georgetown University. Thank you all for being here today. Your written statement will be made part of the record. Each of you will have 5 minutes to deliver your oral remarks. Dr. Holmes, you may go when you're ready.
Good morning, Chair Buchanan, Ranking Member Doggett, and esteemed members of the Health Subcommittee. I'm Dr. Kristen Holmes, Principal Scientist and Global Head of Human Performance at WHOOP, a leading American wearable health platform. I guide the science that powers health and performance optimization for our users. Before joining WHOOP, I was a two-sport athlete at the University of Iowa. I competed for 7 years on the U.S. national field hockey team and later served as head coach of Princeton University's field hockey program, leading the team to 12 Ivy League titles in 13 seasons and securing the first NC2A championship in Ivy League field hockey history. At my core, I'm a coach, a scientist, a mom, and someone who has witnessed firsthand the transformative power of data-driven guidance in unlocking human potential. I believe that proactively managing health at the individual level is our quiet covenant with life, a responsibility we carry not only for ourselves, but for each other. When we empower the individual with insight into how their body is responding to inputs and the general demands of life, we create conditions that make resilience possible, the kind that safeguards us and those around us from adapting to a lower level of mental, physical, and emotional functioning. When adults lack the tools to manage their own health, it becomes increasingly difficult to foster healthy habits in the next generation. We must empower individuals with insights into their own health to not only improve personal well-being, but also lay the foundation for a healthier future for our children. Today, I will illustrate how we have harnessed real-world data to enhance American resilience. While my examples stem from WHOOP, they underscore a broader truth. Health technology and wearable devices are poised to reshape healthcare outcomes, reduce chronic disease rates, and lower overall healthcare costs. But ultimately, this isn't about health trackers. It's about data. For the first time in human history, we have population-level insights from millions of data points on sleep, cardiovascular health, recovery, activity, and behavior. Our mission is to generalize these findings so any human who is interested can follow a path to better health. At WHOOP, we believe health insights should be available daily, not just annual checkups. A prime example is our daily recovery score. Grounded in peer-reviewed science, the score is linked to performance outcomes coaches and athletes care about. But during our company's 13 years in operation, we've discovered these data and insights are not just squeezing efficiencies out of the very best athletes in the world. The greatest impact is on everyday Americans who use our product. I can say with 100% conviction that for many of the everyday Janes and Joes, WHOOP has been astronomically life-changing and in many cases, life-saving. Building on this momentum, we launched HealthSpan. Based on decades of longevity science, in collaboration with Buck Institute, we offer users a very precise lens into their pace of aging, making behavior change both accessible and actionable. WHOOP has also contributed to significant public health breakthroughs. In collaboration with West Virginia University Medical, we identified potential digital biomarker for preterm birth. During COVID-19 pandemic, studies with Harvard and Central Queensland University demonstrated anomalies in nightly respiratory rates could detect infections up to 2 days prior to symptom onset. WHOOP data has also provided operationally relevant insights into psychological resilience among U.S. Army soldiers. We've been able to quantify the effects of call on acute care surgeon burnout. We were the first to publish wearable-driven analyses of cardiovascular and behavioral changes following GLP-1 initiation. These published studies are among the hundreds enabled by WHOOP underscoring its transformative impact on health research. Looking forward, WHOOP is bridging biometric awareness with clinical insight. Our upcoming Advanced Labs feature will integrate key blood biomarkers with continuous wearable data. This fusion will create a dynamic, real-time picture of both physiological and biological health. We're launching health economics and outcomes research, starting with 2 corporate pilots. Industry-wide data suggests wellness initiatives return $1.50 to $6 for every dollar invested. Our study will quantify the impact of WHOOP to help reduce chronic care costs and foster a healthier workforce. All this progress depends on forward-thinking policy. Frameworks like the 21st Century Cures Act and the FDA's General Wellness Guidance have allowed companies like WHOOP to innovate. It is vital Congress preserves and expands these innovation zones. Wellness insights that help people manage their health must remain consumer accessible. In summary, wearable biometric data is transforming from novelty to necessity. WHOOP and other wearables are shifting care from reactive to proactive, episodic to continuous. With smart policy, we can truly put health at people's fingertips, helping Americans live longer, healthier lives. Our society and national security depend on it. Thank you for this opportunity. I look forward to your questions.
And thank you, Mr. Phelps. You're recognized.
Good morning, Chairman Buchanan, Ranking Member Doggett, and members of the subcommittee. Thank you for having me here today and allowing me to share my story. My name is Josh Phelps. I'm the president of Winchester Metals. We're a third-generation family-owned steel distribution, processing, and fabrication small business located over in Winchester, Virginia. Our company roots actually can be traced back to my great-grandfather, who in 1917 fled persecution in Russia and started a new life and a new business here in America, ultimately settling in my hometown of Winchester. But today I'm here to share how small businesses can implement wellness programs to proactively improve the health of their teams. For more than 25 years, I've been responsible for managing our company's health insurance plan, and as anyone involved in this endeavor will tell you, it can be a long, tedious, depressing 6 or 8 weeks each fall until the plan is finalized and you get to present it to your team. I've experienced firsthand how confusing, expensive, and unpredictable this process can be, especially for businesses in the small group market with limited options. Each year, it's the same frustrating exercise. You request a few proposals, you negotiate for some marginal savings, and then you just brace yourself for the premium increases. Employer-sponsored insurance remains the largest source of health coverage in the U.S., covering about 160 million Americans. And this is why most businesses, regardless of size, need to find a way to offer some sort of health benefits to compete for talent in their marketplace. But here's the disconnect. Health coverage is not the same as health care, and neither is it the same as health. The people we employ, with whom we likely spend more time each week than our own families, deserve to be healthy and enjoy life fully. Employers can and should be playing a larger role in promoting healthy teams. About a decade ago, I decided to stop simply reacting to rising costs and started thinking proactively about employee health. I was frustrated with the wellness programs offered by commercial insurance carriers, which usually consist of little more than some questionnaires and online videos in exchange for maybe a deductible discount. These programs rarely addressed root causes of poor health or helped individuals form new and healthy habits. My own decades-long personal passion for health and wellness helped shape our company's new direction. I partnered with a local health coach to customize a wellness initiative for our team. We host monthly, voluntary, 30-minute, on-the-clock sessions to teach practical health concepts, like how to read a nutrition label, understanding portion sizes, ways you can cook meals at home, and recognize the impact of exercise on mental health, among other topics. We've never required participation. We've never tracked results or added pressure. Instead, we focus on creating a culture of curiosity, empowerment, and long-term habit change. We have some friendly competitions. We do step challenges. We did a no sugar challenge. I'm right now wearing a continuous glucose monitor. We're seeing how everybody does on tracking their glucose control. So we do things like that in order just to encourage participation and make it kind of fun. A couple years ago, we added another layer where we started partnering with a local direct primary care practice. We now fully cover the cost of direct primary care membership for any employee who chooses to have that option. About half of our covered employees now have chosen that option, and to my knowledge, no one who has ever made that switch has ever switched back to a traditional direct primary care physician. It's been a game changer. The relationship-based care that that DPC provides is really second to none. I get asked a lot by other small businesses, how do we measure success in this program? And the truth is that we don't, not in the traditional sense. Insurance carriers, especially small groups like ours, we don't get access to a lot of data, so I can't really have any metrics to measure against. And then if you change providers for cost savings year after year, you might lose those historical trends. But what's the importance of a wellness program like ours is prevention. And you can't measure things that don't happen. What's the value of a heart attack that never happens? What's the value of someone not getting type 2 diabetes? What's the value in someone not missing work or family time because they're ill? And we hear these stories all the time. People change their grocery shopping habits. People start meal prepping at home. People start home workout with their family or their spouse. These things, while not measurable, are invaluable. In 2021, I co-founded a podcast called Healthy Team, Healthy Business, where we encourage and help other small business owners navigate this idea of wellness programs in their businesses. We've interviewed a variety of health professionals, including mental health, physical health, financial health, all those topics that we cover. Programs like the one I talk about work because they're flexible, community-based, and tailored to our small workforce. We're not looking for mandates. We'd like some new tools, like some of the wearables you're going to hear about today. But ultimately, empowering employers and employees to focus on health and not just health coverage is what really is going to make the difference in our national health picture. I appreciate the opportunity to share with you today, and I welcome your questions. Thank you.
Thank you, Mr. Z. You're recognized.
Good morning, and thank you, Chairman Buchanan, Ranking Member Doggett, and distinguished members of the Health Subcommittee. I'm honored to speak with you today regarding the role that remote patient monitoring plays in empowering patients by collecting, analyzing, and displaying digital health data to patients and to their care teams. Whether you prefer the adage, measure twice and cut once, you can't change what you don't measure, or what gets measured gets done, it is clear, to make America healthy again, we must start by taking the measure of the patient. My name is Andrew Zengilowski. I am a co-founder and the Chief Executive Officer of CoachCare, and I'm a founding member of the Remote Monitoring Leadership Council. For more than 10 years, CoachCare has offered remote patient monitoring technology to independently owned physician practices. We are an extension of the clinical staff, and we focus on achieving improved clinical outcomes, practice efficiency, patient satisfaction, and a lower total cost of care. The Remote Monitoring Leadership Council is a collaborative of 7 innovative companies operating across all 50 states and collectively offering the majority of remote patient monitoring services being delivered to Americans today. Members of the committee, thank you for taking the time to discuss the importance of digital tools as part of our healthcare future. Each of you have constituents benefiting from RPM as we sit here today. And each of you have independent physicians living or working in your districts that rely on remote patient monitoring to treat their patients and to retain their independence. While delivering high-quality RPM is complex, at its core, RPM is a simple and common-sense service. For decades, physicians have instructed patients with hypertension to buy a blood pressure cuff, take their measurements at home, and keep a log. They have been instructed to bring that log back to their next appointment, usually 6 or 12 months in the future. RPM technology represents a simplification and enhancement of this common practice. We ship to the patient connected, FDA-cleared medical-grade devices to track vitals. We use FDA-cleared devices to ensure that the data we receive is valid for use making life or death clinical decisions. We also pull data from consumer-grade wearables, such as those that Secretary Kennedy discussed during yesterday's House Energy and Commerce Committee hearing, to provide context. While we can't use consumer products to make medical decisions, we can benefit from the additional context that they provide. The data captured by these devices is transmitted to our software, analyzed, and presented both to the patient and to their care team. This allows near real-time interventions, often avoiding the emergency room and preventing costly hospitalizations. Hypertension is called the silent killer for a reason. The first symptom a hypertensive patient usually experiences is a heart attack. We are going to talk a lot today about the dollars and cents of digital health, and I thought it important to take a moment to acknowledge that we are also talking about life and death. These catastrophic and costly outcomes are avoidable by monitoring the patient and using the data we collect to titrate medications and adjust lifestyle factors in near real time. We are going to talk a lot about primary prevention today, but we should not discount the importance of tertiary prevention. We cannot ignore the more than half of the adult population in the United States who already have at least one chronic condition. Members of the committee, I have good news. RPM is incredibly inexpensive. I can monitor a patient for 50 years for the cost of an ambulance ride and a few days in the hospital, which is unfortunately a near certainty if we do not manage these chronic conditions. Across a cohort of 450 patients suffering from advanced chronic heart failure that CoachCare manages, we reduced the hospitalization rate from 19.8% to 1.7%. When applied across the more than 6 million Americans diagnosed with CHF, a similar reduction in hospitalization rate would save $24 billion annually. We believe RPM is a flagship example of harnessing the power of digital health because without patients and providers having vital and valid data at their fingertips, neither can be an active participant in ensuring better outcomes, and money will be wasted. Additionally, leaders in the RPM space are moving toward models that leverage AI to fully realize the potential of the voluminous patient data captured through RPM. AI is helping to detect conditions sooner, lessen the burden of paperwork, and support clinicians in making optimal care decisions. Actions from CMS to specifically support data and technology costs are crucial to unlocking the potential of advanced data capabilities like AI alongside RPM. We urge the committee to work with the industry to modernize RPM payment to ensure continued expansion of this proven digital health tool while safeguarding program integrity. Medicare cuts unrelated to the performance of RPM have continued, ranging from 7% for treatment-related services to an astounding 33% for technology-related services. RPM providers, particularly small providers who operate on tight budgets, are reaching a breaking point. I appreciate the subcommittee's attention to this very important topic and the opportunity to testify.
Yeah, thank you. We're trying to keep the remarks to 5 minutes. Everybody's got somewhere they need to go. We want to get everybody in as best we can. Thank you, Dr. Gerhart. You're recognized.
Chairman Buchanan, Ranking Member Doggett, and members of the committee, thank you for the opportunity to testify today. My name is Jackie Gerhart. I'm a practicing family physician and chief medical officer at Epic, a health IT company based in Verona, Wisconsin. Epic creates software used by hospitals and health systems in all 50 states. Many of you and your constituents are already using Epic, using the MyChart app on your phone. Through MyChart, you can see test results, schedule appointments, or even sync data from wearable devices. We've been connecting device data since 2012, and we're among the first to integrate with Apple HealthKit in 2015. Connecting patients, clinicians, and their data isn't just convenient, it improves care. When I was seeing obstetric patients in my practice, I cared for mothers with postpartum hypertension, a serious condition that can lead to seizures or even death. These patients had to come into my clinic every day for blood pressure monitoring. Now, I'm able to prescribe a connected blood pressure cuff that syncs through Apple Health, allowing me to monitor things remotely. This prevents ER visits, reduces costs, and provides critical support for patients in rural and underserved communities who otherwise would have faced long drives and limited access. That kind of early innovation laid the foundation for what's possible today. Today, generative AI is improving care in ways that are both practical and powerful. It helps draft clinical notes based on my conversations with patients, giving me more time to connect with them face-to-face. For example, at Reed Health in Indiana, this reduced physician documentation time by 86%. And at John Muir Health in California, this decreased physician job turnover by 44%. Moreover, AI can suggest appropriate orders, summarize complex care, and surface insights on the patient. It even simplifies prior authorization by searching the chart in a matter of seconds to find the documentation insurers require. And sometimes, it catches what otherwise might be missed. At the Christ Hospital in Ohio, AI reviewed routine chest X-ray reports for incidental findings that could have been overlooked. That led to over 100 cases of lung cancer being detected earlier. While the national average for early detection is 27%, they are identifying it early in 70% of cases, saving lives through timely follow-up. As one of my colleagues put it, AI is the best resident I've ever had. But our goal isn't to recreate a resident. It's to assist physicians with tools that anticipate, guide, and elevate care. Another advancement we're working on is the seamless flow of data to ensure clinicians have the complete picture of their patient's health. Through interoperability, health systems used Epic to exchange more than 700 million patient records to inform treatment in this last month alone. Half of those exchanges were with organizations not using Epic EHRs. Last year, more than 750 third-party apps used Epic's publicly available tools to help patients retrieve their own health data. And health systems using Epic responded to more than 111 billion interoperability calls, enabling a broad range of novel app integrations. We believe that TEFCA, as a federally endorsed trust framework, has great potential to expand interoperability. The Epic community has connected more than 1,000 hospitals and 25,000 clinics through TEFCA, and more are being added each month. As data exchange grows, so does the need for strong, consistent privacy protections. Today's privacy protections vary depending on who holds the data. Many people believe HIPAA requires that their medical information be kept private no matter who is accessing it. That is not the case. HIPAA only covers actors like health systems, insurers, and their contracted business associates such as Epic. This is confusing for patients. They may not understand that their data is subject to different rules depending on where it goes. One reason we support TEFCA is that it requires participants to adhere to higher privacy standards. Having said that, we encourage the federal government through legislation or regulation to close potential gaps under HIPAA to better meet patients' expectations. Anyone sending or receiving health data through TEFCA or any other exchange network should be held accountable under HIPAA. In closing, Epic is driving the next way of innovation through digital health, AI, and interoperability. These innovations are helping us care for our patients better by delivering safer, smarter, and more patient-centered care. Thank you.
Thank you, Ms. Corlette. You're recognized.
Thank you, Chairman Buchanan, Ranking Member Doggett, and members of the Subcommittee on Health. My name is Sabrina Corlette, and I'm a research professor and co-director of the Center on Health Insurance Reforms at Georgetown University's McCourt School of Public Policy. Thank you for inviting me to testify today. My comments here reflect my own views and do not reflect the views of Georgetown University or the McCourt School of Public Policy. Unfortunately, having a hearing about digital health technologies at a time when 16 million people are about to lose their health insurance coverage, premiums are projected to skyrocket, and millions of people with insurance will face higher out-of-pocket charges is akin to Marie Antoinette telling the people of France to eat cake. People cannot take advantage of technological advances in healthcare if they do not have health insurance coverage or face insurmountable financial barriers to healthcare services. Therefore, I will be focusing my remarks today on how proposed federal policies, in particular the House-passed H.R. 1, will affect people's access to affordable, high-quality health insurance. The $1 trillion in cuts to healthcare programs in this bill will lead to an over 50% increase in the number of people who are uninsured. H.R. 1 amounts to a stealth repeal of the Affordable Care Act, a law that now covers roughly 1 in every 6 people under the age of 65. The people covered under the ACA are early retirees, gig economy workers, small business owners, self-employed entrepreneurs, students, caregivers, and millions more who work hard but whose employers don't provide health insurance. H.R. 1 would also have a devastating impact on healthcare providers, particularly those serving rural and underserved communities. I will just touch on a few damaging provisions in this bill. Under H.R. 1, states must implement a work requirement for their Medicaid programs. There is broad consensus across the research literature that the proposed work requirements will do nothing to increase the amount that people work. Instead, it saves the government money because millions of people who are working get cut off because they cannot navigate the red tape. H.R. 1 would also require all states to charge cost sharing to Medicaid enrollees. Again, the research is clear. These financial barriers will lead many to forego needed services, leading to worse health outcomes and higher costs in the long run. Touching now on the marketplace provisions in the bill, 8.2 million people are projected to lose insurance due to the combined impact of Congress's failure to extend the enhanced premium tax credits and the marketplace provisions in H.R. 1. The changes on the horizon will not only increase uninsurance, but have a significant destabilizing effect on the marketplaces and tie the hands of states that have, until now, had the primary authority to regulate their insurance markets to meet the needs of their state residents. Indeed, in states with early filing deadlines for insurance companies to submit premiums for 2026, this is why we are seeing eye-popping increases. For example, insurers in Tennessee have proposed a 24% premium increase, 19% in Pennsylvania, 13% in New York, 13% in Massachusetts. The provisions in H.R. 1 would limit eligibility for marketplace premium tax credits and impose burdensome new paperwork requirements. Lastly, although there has been considerable rhetoric suggesting that the budget reconciliation package does not include cuts to the Medicare program, that is simply not true. In fact, the bill would cause significant harm to millions of Medicare enrollees and the providers who serve them. In particular, under statutory pay-go, H.R. 1 would trigger a mandatory sequestration resulting in, as Congressman Doggett noted, a 4% reduction in pay to providers every single year. In closing, cost-effective and innovative technologies that can help people better track and control chronic conditions are exciting opportunities, but people need to be able to access and afford health coverage in order to take advantage of such technologies. As drafted, H.R. 1 would actually make it harder for people to obtain health care, tying them up in a maze of bureaucracy, raising their premiums, and imposing new federal mandates. Thank you.
And thank you. We'll now proceed to questions and answer this session. Dr. Holmes, let me ask you, there's been a lot of progress made with multiple companies and as well as yours. What do you see as the future in the next 3 to 5 years, 7 years, but let's say next 2 to 4 years? I'm very excited about the possibilities because I'm a big person in prevention. I don't want people to get heart attack and cancer in the first place. Any way we can minimize that is a great thing to the country. We're spending $5 trillion and people are getting sicker. What we've got doesn't work. So I think this will move us somewhat in the right direction, give people a choice. And I hope employers pick up what Mr. Phelps is doing, because we need to have companies investing in their employees. But why don't you tell us your thoughts and where your vision about where this industry is going to go? And I was excited to hear the secretary yesterday mention that he'd like to see everybody with some kind of a medical device that they can monitor their own activity in the next 4 years. So we'll see how that works out, but I'm excited about that. But go ahead, Doctor.
Thank you for the question, Chair Buchanan. Yeah, I mean, I think at a very basic level, helping people understand their baseline is very much what gets us excited in terms of helping people manage their own individual health. We have to make that the norm. No one is coming to save us, right? We have to be, and you said it yourself, Mr. Buchanan, that we have to be the CEO of our own health, right? I mean, that is the promise of wearable technology, is that you can understand changes in baseline and how they might be linked to various lifestyle factors, right? So this is, I think, for me, at a basic level, that's what's exciting. I think there's also an opportunity to tie together blood biomarkers with the physiological data to give people a more holistic picture and get ahead of what are preventable diseases.
Mr. Phelps, I've been an employer for 30 years before I got here. Your biggest asset, as you know, are your employees. You want them to be as well and be able to perform their job at a high level, and also big benefit to them and their family and everything else. What can we do to try to get more small businesses? And by the way, how many employees do you have?
We're 46 employees.
Okay. How do we get other businesses involved? Because it just seems like it's such the right thing to do. And I've always heard if you help other people get where they want to go, if they want to go that way, it puts you in a better position yourself. So I'm excited to hear what your company's doing, but we need to have more small businesses and more companies. A lot of the large companies are doing some of it, but we need more to encourage it. Someone doesn't have to do it, but we want to make sure that they're educated, they got an opportunity to hear the message and see if they can, if that makes sense to them. But what's your thoughts on what more we could be doing or encouraging people to do?
Yeah, the first thing is just get over this fear that there's conversation you're not allowed to have as an employer with an employee is talking about their health. It's something that, for some reason, we just feel like it's not part of our daily role as an employer or a manager. The second is that it's not expensive. It doesn't have to be expensive. You can make it as elaborate as you might want, but stopping somebody or a group of 4 or 5 people for 15 or 20 minutes and having a simple conversation about using glass instead of plastic or a wearable. Those kind of things are not things that disrupt your work day. They do not have to cost you a lot of money, a lot of productivity, et cetera. And who knows what impact you're going to make. And third, I think there are resources out there if you look for them, probably in your own communities. And I mean, my community is not a big community; it's small. But I had choices when I started looking for coaches and other people to bring in to help us with this. Just did a little bit of shopping, a little bit of elbow grease, and got it figured out. And then educate yourself. I got myself certified as a health coach just in case the stuff with our wellness coach that we hired didn't work out. I could do the stuff myself. That was the impetus of us doing it, and I think other employers can do the same thing. It's not that hard.
Thank you. Mr. Doggett, you're recognized.
Thank you, Mr. Chairman, and to all of our witnesses. Professor Corlette, let me begin with you. You begin where you left off, which was on Medicare sequester. President Trump, of course, promised earlier this year that he would, quote, love and cherish Medicare and Medicaid. This bill appears to me to be taking a wrecking ball to both. You talked about the Medicaid part, but on Medicare, what are the effects of the sequester that is triggered under this bill that begins in a very short time, October 1st, to begin cutting the payments that go to all healthcare providers, independent physician practices we've heard about, hospitals, labs, everyone. And at a time that we know that many practices are already closing, it's become increasingly difficult to have independent practices because hospital-based or facilities are becoming increasing. Those considering medical school that come to see me, the students, whether they're physicians or dentists or any number of other healthcare providers, are talking about the immense amount of debt that they incur in medical school. What's the effect of beginning to cut year after year the payments as a result of the incredible debt that's being added from this bill? What impact does that have on providers and on those who rely on those providers?
Thank you, Ranking Member Doggett, for the question. Under statutory pay-go, the budgetary effect of H.R. 1 would trigger a mandatory sequestration to reduce federal spending, totaling $45 billion in 2026 and roughly $490 billion between 2027 and 2034. And as you noted in your opening statement, that means that each year providers would face a 4% cut in their reimbursement. When you combine that with policies that increase the numbers of uninsured and limit the ability of states to raise revenues to increase provider payments, these cuts would have severe financial consequences for providers, particularly those in rural and underserved communities. These financial pressures are likely to harm the quality of patient care, limit the availability of critical services, result in layoffs of key personnel at facilities and other practices, and in some cases lead to hospital closures. And in fact, there's an analysis out from the University of North Carolina finding that an estimated 300 rural hospitals would be at disproportionate risk of closure, conversion, or forced reduction in critical services as a result of this bill.
Thank you, and it's great to hear about the innovations, the opportunities for improving care with personal devices. Of course, none of those would be available to us if we hadn't had someone who is creative and given an opportunity to do that, combined with a risk taker to put those products out on the market, I'm concerned about the research cuts that are being made in the president's budget and through his bill. At the University of Texas, I talked recently with a professor who has already earned more than $100 million for the University of Texas in royalties from his viral research. His project, his grant, was cut off just a few weeks before it was to be completed with 1 week's notice. And he told me of other folks around the country relying on federal research dollars from the National Institutes of Health. Some had animal studies, some had patient studies on many of the dread diseases that we all fear, and cut off with similar lack of notice. NIH has funded at the University of Texas research on ultra-processed foods and the impact on diabetes, educational tools to slow the decline of Alzheimer's, and new discoveries on antimicrobial research. These are just a few of hundreds of projects that place UT Austin as the 14th in the world for interdisciplinary science, a position that's clearly endangered. Have one department after another expressing concern about cuts from the National Science Foundation and National Institutes of Health, and what impact that will have on whether we have future generations of new technologies that we will be able to benefit from. Can you discuss a little what the impact on these cuts for scientific and medical research?
Absolutely. I think it's well documented that for every $1 that we spend on the NIH, it returns $2.56 in economic activity. So it's a great investment. Unfortunately, the president's budget includes a 43% cut to next year's NIH budget, amounting in about $20 billion of lost research opportunities each year. This means that research labs are implementing hiring freezes, laying off staff, clinical trials are being put on hold. The ripple effects are absolutely enormous. And we know 99% of new drugs that were approved between 2010 and 2019 were developed thanks to seed funding from the NIH. The proposed cuts, by one estimate, would destroy the equivalent of 1/4 of our annual GDP in the U.S. So really biting off our nose to spite our face. I'll also note that my colleague here mentioned that the remote monitoring technology relies on FDA approval, many of them. And I will just note that the layoffs and turmoil at the Food and Drug Administration are likely to slow down the review and approval process for drugs and medical devices, leading to delays in bringing these vital new technologies to patients.
Thank you very much.
Thank you. Mr. Smith, you're recognized.
Thank you, Mr. Chairman. Thank you to our witnesses as well. These are exciting topics to discuss. And, looking back at what has been done in healthcare or what has not been done, certainly I'm glad that the last witness to testify has expressed her indignation at increased insurance premiums. And we've seen a lot of those over the last few years. I think of in Nebraska, we had a high-risk pool with a high premium. Yeah, I understand that. Now everyone in the individual market has to pay those high premiums. What has been the solution out of Washington? We subsidize premiums. This is not sustainable. I might even suggest that double payments and duplicate payments, some would consider very good for the economy. And yet, is it sustainable? So how can we work together to find more efficient means of delivery of health care that actually results in better health? What a concept. I'm concerned that the federal interventions in healthcare of the last several years has just shifted around who pays how much. No apparent improvement in health across America, and yet patterns, fiscal patterns across America that are not sustainable. And I think we need to pay very close attention to this. So that's why I'm excited about new technologies. I suppose some of these newer technologies will be a little bit disruptive to billing patterns, and we'll hear from some folks who say, oh, this could be dangerous. And yet, it's oftentimes the right thing to do, and to pursue innovations for the future that help people. And quite honestly, yes, I want to save taxpayer dollars too, but it's in the dignity of helping people get to a better place with their health care, with their financial situation, and others. And I have one of the most rural districts in America where telehealth, we've done some work on that for the purposes of rural application, but COVID showed us that we need it in urban areas too. And so certainly remote patient monitoring is a form of telehealth that I'm very excited about, so we can have that very valuable visit to a physician perhaps can mean more when data is already available even before the patient walks in the door. And so I'm very interested in terms of, there's some moving parts here of how can we make sure folks have access in rural America. Broadband coverage and internet access is not what it is in other places, so I want to be working on that as well. But obviously there are going to be some barriers. And so, Mr. Zengilowski, I was wondering, given your experience in integrating remote patient monitoring into smaller practices, what barriers, other than connectivity perhaps, would you say you've encountered with expanding the usage and utility of RPM?
Yeah, thank you for the question, Representative Smith. I appreciate it. Comments as well. A quick note on connectivity. I do think industry has largely been able to identify various different devices for patients in different areas, whether they have internet access or not. We have a device that will work for the patient. In terms of when we think about the rural patients, what is preventing an expansion of remote monitoring services to that patient population? It is the disparity, the geographic disparity in reimbursement rates. Rural populations, rural physicians are reimbursed significantly less for the same services than physicians in other areas. And Representative Kustoff has introduced H.R. 3108, which aims to solve that problem.
Thank you. Well, the challenges that we face in terms of actually increasing access and having positive outcomes to where the American people are healthier, I think discussions like we are having today are what we need to do. The American people want to see results. They don't want to just see more centrally planned health care coming out of Washington, D.C. that delivers exactly no improvements across America, and certainly a more efficient application of tax dollars. So really it's what we should be keyed in on what the American people want us to do and expect us to do in a very efficient manner and to show results. So thank you, Mr. Chairman, again for this hearing. Very timely and appropriate. I look forward to the continued discussion. Thank you.
Thank you, Mr. Thompson. You're up.
Thank you, Mr. Chairman, and thank you to the witnesses for being here today. I want to associate myself with Mr. Doggett's comments about all the great technology gain that we've seen and the potential for even more. But today's hearing, Health at Your Fingertips, is really hard to take seriously when Republicans are ripping health care out of the hands of millions of hardworking Americans. How can we talk about digital health management tools when people won't even be able to see a doctor? This hearing is a distraction from the damage the Republicans' one big ugly bill will have on our health care system. Under the big ugly bill, some hospitals and clinics in my district and across our country will shut down. Others will have to reduce and lay off staff. More than 16 million Americans, including kids, will lose their health care coverage, all to give tax breaks for wealthy people who don't need tax breaks in this current environment. This is the largest act of health care theft in modern history. Hardworking families don't need more apps and futuristic health gadgets. They need access to affordable health care. They need prescription drugs that don't break the bank, and they need hospital visits that won't lead to bankruptcy. This technology that we're experiencing in today's world is good stuff. There's no question about that. But you need people to make it happen. Someone mentioned the remote monitoring. I can't tell you how many nights I was woken up because
someone on a health monitor was having problems, and my wife had to go and respond to those problems. There's a person attached to all of that. It just doesn't, the machine just doesn't do it all, and that needs to be recognized. There's also privacy concerns with the digital health technologies that we're discussing. When DOJ gained access to sensitive personal information of millions of Americans, this issue was truly highlighted for all of us. This is not to say that digital healthcare technologies don't have benefits. We all know that they do. And I'm a strong supporter, as my colleagues know, I've been pushing it for a long time on this committee, of telehealth. And we've worked to expand telehealth services, and we're really seeing the benefits of that. But none of these tools matter if Americans can't afford to go to the doctor, if they're being stripped of their coverage, or if their private health information becomes compromised. And we need to recognize that up front. Dr. Gerhart, many Americans are rightly concerned about how their sensitive health data is collected, shared, and potentially misused. As a family medicine physician, do you think that DOJ should have access to the medical data of the patients that you care for?
I can't speak specifically to DOJ, but we do feel that it's confusing for patients what happens to their health data. And we believe that HIPAA should be expanded to cover all entities exchanging patient health data.
You don't think that just anybody should be able to come in and collect these data from people's personal health care records?
We feel that HIPAA should be expanded to be able to cover all of those entities.
I agree with you. Thank you very, very much. Ms. Corlette, there's no doubt that digital health tools have the potential to help individuals improve their health and overall well-being, but they only help people who can actually, I believe they can only help people who can actually access care. Given the Republican proposal that would cut over $1.5 trillion from the health system and kick 16 million Americans off their coverage, how do you believe their policy would impact the ability of Americans, especially low-income and rural communities, to benefit from digital health technologies?
Thank you for the question, Mr. Thompson. Unfortunately, one of the first effects of the bill is to terminate insurance coverage for as many as 16 million people. When you don't have insurance coverage, the evidence is clear. You don't have access to a regular source of care. You wait till the last minute to seek care, and certainly you don't have access to some of the technologies that we're talking about today. The second thing that I would like to mention, and one thing that's sort of fallen under the radar screen with respect to this bill, is that it would also increase annual cost sharing for people with employer-based insurance for families by $900 a year.
Okay, thank you. Mr. Chairman, I'd like to submit to the record, if you would, these sheets of the different technologies ranging from $500, $800, the ring that you're wearing, $520, $525.
Mine's was only 300, so.
Yours is only 300?
Yeah,
All right.
I got the cheap one.
But that's good. But even the people who are losing their health care because of the big ugly bill can't even afford the $300 cheap one. I'd like to submit this to the record, Mr. Chairman.
Yeah, without objection, so ordered. Thank you.
Thank you.
Thank you. Doc, go ahead.
I was talking about an ectopic pregnancy. Thank you, Mr. Chairman. This is an excellent hearing. It brings me back to the fact that actually the world is not round anymore; it's turned flat, because it's on our phones, it's on our TV screens, and that's the way we're actually conducting healthcare. I practice in a very rural part of eastern North Carolina. Our payer mix is, truth be told, horrible. Close to 75% Medicare, Medicaid, and no insurance. These are impoverished rural individuals. But the fact that our healthcare system has done an unbelievable job in turning telehealth and telemedicine into allowing impoverished individuals to get healthcare truly is to be lauded. I'm going to give you a few examples. Electrophysiology, we have an implanted cardiology devices which can follow patients that live an hour and a half away and see exactly what their their rhythms are, fluid retention, et cetera, so we can intervene early in heart failure and doing so many different things. Telecardiology visits. We're able to talk to patients either via their phone, TV, or if they go to the library, they can get on a computer, save thousands of dollars in travel, but more importantly, actually keep them healthier. And this is done in a rural, impoverished area where people have access to care because of the things that we do. Same thing with teleneurology, stroke intervention. As you guys may or may not know, the earlier you get in on strokes, the infinitely greater chance of survival and less defects that people happen. It is unbelievable what's happened in the last 3 years. I've practiced medicine close to now 35 years, and we are in warp speed now as to what we're able to do. Let me go a little bit, Dr. Gerhart, because our system was actually one of the first users of Epic. I cussed and fussed, and it pissed me off for days on end trying to work with a computer about 20 years ago. Thankfully, things have changed tremendously since then. Now, even though our system, I don't know why, has not adopted ambient listening, I'd love you to just comment briefly on what ambient listening is and how it changes healthcare, how it changes the experience for actually the people providing the healthcare, the physicians.
Yes, thank you for the question. So ambient technology is, as when I'm the physician, I can take my phone, place it between myself and my patient, and I can ask for the patient's consent to record. And that allows me to focus on the patient, look them in the eyes, actually have reconnection with the humanistic type of medicine. And the visit is recorded for me and my note is written for me. And that is one of the biggest things that we've noticed to be helpful from a burnout perspective that we've ever seen. And it's been saving marriages. It's been, some people say it's the best resident.
No, I shouldn't. I love, my wife has survived 35 years as a surgeon, God bless her. And I don't know how many hours of my life that I've lost dictating. And now I'm coming towards the end of my career, and it's finally occurred. One thing, there is a caveat here, guys. There is a caveat. You have wearable devices, and then you don't have doctors or even clinical nurses sitting in rooms all the time looking at hundreds of different EKGs, labs, et cetera, et cetera. There's a major liability issue because we know our wonderful trial lawyers are swirling around ready to jump in at any moment of time. You talk about wanting to expand HIPAA. I can't agree with that. Look, HIPAA, I can't, if a 19-year-old college student comes in with a kidney stone, I can't talk to her parent without me getting express consent. I think we've gone a little bit too far on some of the HIPAA things. Quickly, if you can, I want to ask you about interoperability with other systems, Oracle, for example, because this was one of the things that actually was good with the ACA. It said systems had to communicate with others. Here we are a decade later, still not happening. Can you help me out with that? Because I asked Judy about that about 2 years ago, and I didn't get a great answer.
Okay. Well, thank you for the question. Epic does exchange 700 million patient records a month, and half of those are with non-Epic EHRs, so an example being Oracle.
I think that's a good step in the right direction. Our VA, I serve on Veterans Affairs, our VA needs to get, it's ridiculous. They've been working with now Oracle for 15 years, and we have nothing to show from it. And I still see veterans, and it needs to happen across all systems. One thing I wish you would do, and carry this back to the Epic people, I'm an old person. I've been practicing medicine a long time. I have to look at a computer screen. Every year, you guys change the color of the screen, move the things around. I'm used to pushing up here to order things, and now it's down here. Stop it. I'm old, okay? Stop doing that stuff. Just give me the same damn screen every year. I'll be a happy camper, okay? I know that's the secret sauce, how you come in and charge $70 million for a new screen every year. Stop doing that. It's annoying. All right. Thank you very much. I'll yield back.
Yes, Ms. Corlette, now I wear an Apple smartwatch. It measures my heart rate, wrist temperature, and blood oxygen. But even though I appreciate that information, I must point out that if my heart rate is too high, you would think I should see a doctor. But with the devastating cuts to healthcare that would come about because of H.R. 1, in fact, we would have the most devastating cut to healthcare in our nation's history. And in fact, you laid out that the Republican reconciliation bill would slash more than $1 trillion from our healthcare system, gut Medicaid by over $800 billion, and would cause 16 million people to lose their coverage. At the same time, This bill undermines the very pillars of the ACA that have helped millions of Americans access care, including by eliminating the premium tax credits that makes the ACA plan affordable for so many. So, Ms. Corlette, if Republicans succeed in eliminating the ACA tax credits, millions of people could see their premiums rise by up to 64%. And that's exactly what my constituent, Jacob in Pasadena, fears. He's relied on ACA coverage since 2014, and the enhanced tax credits are the only reason his monthly premiums remain manageable. I also heard from Davis, another one of my constituents from Pasadena, who told me that his 77-year-old mother relies on both Medicaid and Medicare, as well as the assisted living waiver provided through Medi-Cal for affordable housing. He told me that if she loses her Medicaid, he will have no choice but to move her into his apartment, get a second job, and become her full-time caregiver. So, Ms. Corlette, if my constituents, their families, and millions of Americans across the country get kicked off health care under the Republicans' big, ugly bill, how are they supposed to pay out of pocket for wearable technology or digital health tools? How much harder would it be for them to reap the benefits of those tools, let alone then follow up with a doctor's appointment?
Thank you, Congresswoman Chu, for the question. I think that the simple answer is that most of them won't be able to pay for these technologies, which I think are very exciting and hold a lot of potential. But we know that particularly for low-income folks, even small dollar amounts that they have to pay out in order to access care result in them just not getting the care at all and delaying it or foregoing it completely. And then, of course, what happens is that the condition that they have gets worse and it becomes an emergency and they end up in the emergency room. So the bottom line is that when you take away health care from people or impose large financial burdens on them to access care, they simply don't get it, and health outcomes get worse and costs go up.
Thank you for that. Now I'd like to ask you about privacy protections, because most digital health apps are not subject to HIPAA standards. Consumers are often misled into thinking their data is protected, when in fact these apps can collect, store, and even sell personal health information to third parties, including law enforcement. Yesterday marked the 3-year anniversary of the Dobbs decision, which eliminated the constitutional right to abortion and stripped millions of Americans of the freedom to make choices over their own bodies. Since then, we've seen growing efforts to criminalize abortion and a dangerous new reliance on digital data to survey and prosecute women. Concerningly, a 2024 Forbes investigation found that period tracking apps routinely obscure their privacy practices and enable third-party data sharing, failing to disclose when law enforcement requests user data. So, Ms. Corlette, can you address these issues about privacy concerns and how Republicans' massive cuts to Medicaid and the ACA further restrict Americans' access to reproductive health care?
Yeah, thank you again for that question. I am very, very concerned about the privacy risk that people take on with some of these wearables, particularly in an environment where you could be prosecuted for exercising bodily autonomy. I'll also note that unfortunately the H.R. 1 also defunds Planned Parenthood, which means that the patients who rely on these critical healthcare services will be blocked from things like family planning, prenatal care, in addition to abortion. Also, women make up over half of adult Medicaid and Marketplace enrollees, and so they will be disproportionately impacted by the termination of health insurance under this bill. And when you don't have insurance, it's difficult or impossible not only to access your reproductive health services, but all healthcare services.
Thank you. I go back.
Thank you, Mr. Yeah, go ahead.
Thank you, Chairman, and we'll try to get back to the whole reason we're having the hearing today. Coach Holmes, congratulations. I grew up in an era where our gymnastics coach was also our football coach, and he started using tubing instead of lifting weights in order to get flexibility and strength at the same time. So it was always, you can't make the club in the tub. The idea was you got to be on the field, you got to be moving. Mr. Phelps, the worst thing that can happen to any employer is to lose somebody productive on the line. The idea is productivity all the time. If you can't work, you can't produce. If you can't produce, then somebody else has to pick up the tab. All of you are doing the same thing. I had the privilege of sitting beside a doctor, not every day, but on meetings like this. I really would like to get back to what it is we're doing that makes it much easier, much quicker, much more efficient. In the automobile industry, all the technology was about keeping people out of the shop so their warranty costs would be lower, including offering free lubrication, tire changes, and everything else, because the cost of replacing far exceeded the cost of keeping them active. So at this point, Mr. Chairman, I'm going to pass my time on to Dr. Murphy. This is what he's done his whole life, and I'd rather listen to experts and people who stay true to their cause.
Thank you, my good friend. You look very well today, by the way. Just a question I have, because I think we got a little bit sidetracked about this. It is amazing that we have the information and the technology to do the things that we couldn't do 5 years ago. But is it government's role to be everything for everybody? So, Ms. Corlette, I got a question. Do you think people who are not veterans should receive health care from the Veterans Association?
Sorry, could you repeat the question?
So, do you believe people who are not veterans should receive health care from the Veterans Association?
From the Veterans Association?
Administration, sorry.
That is not something I'm qualified to answer. I'm not familiar.
Well, it's
with
just kind of the
rules
same thing
governing.
can you define a woman? It's the same kind of thing. People who are not veterans should not receive health care from the Veterans Administration. And they talk about people losing health care. We have Medicaid, and I hope this isn't news to people. Medicaid is for pregnant females, the impoverished children, disabled, and those with dual eligibility when they are seniors. Those are the eligibility criteria for Medicaid. We have now people who, for the Biden administration, did not allow the states to audit their Medicaid rolls for several years, so people were on Medicaid who did not deserve, by eligibility criteria, to be on Medicaid. So those people don't need to be on Medicaid. Number two is we had an influx, we had an invasion, the greatest invasion of this nation occur during the last administration. Anywhere between 13 and 20 million individuals came into this country. I've taken care of individuals who cannot pay my entire life, not only here in this country, but abroad. Is it the taxpayer's responsibility to default on this nation's debt because we had people come into this country illegally? No, it is not. No, it is not. And then finally, able-bodied individuals who I see in my clinic who are receiving benefits from this government while they could be having a job, because good Lord, there are jobs out there, who could be getting health insurance. As you pointed out, Mr. Phelps, the largest supplier of health insurance in this country is the private sector. Why is it that the ineligible, the illegal, and the able-bodied are receiving health care benefits on the back of the taxpayer? So we talk about these people losing health care. They were not eligible to begin with. So we don't, as a business of a government, need to be supplying resources and benefits for individuals who do not meet eligibility requirements. Sorry. That's just a fact of government. And if we want our government to default and become everything for everybody, we continue on this track. Look, I've taken care of people that don't have a damn dime in their pocket. And there are resources that I have used out of my own pocket to do it. We can't do that as a country. So yes, it has to be certain cuts, and it has to happen in every single segment. And yes, the top 10% of earners in this country pay 75% of the taxes. Why don't we just make them pay 100%? Then people wouldn't have any argument about it. Then you kill the inability, or you kill the incentive actually to work harder. It's called government. It's called accountability. And I, for one, am damn glad that we finally have an administration over Republican and Democrat administrations for years prior that actually cares about the future of this country by putting our pocketbook and our wallet in the right place and stop spending money on things that people are not eligible for. Thank you, Mr. Chairman. I'll yield back.
Thank you, Mr. Hearn. You're recognized.
Thank you, Mr. Chairman. Thank the witnesses for being here today and for sharing your thoughts on this really incredible topic. We should all be supporting and employing new types of technology in the healthcare space, and it's a great sign that we're talking about this in the halls of Congress. I'm particularly interested in digital therapeutics, FDA authorized evidence-based software that delivers clinical intervention used to treat conditions like PTSD in veterans, insomnia, and chronic disease. These are great tools that are often paired with telehealth and remote monitoring to offer personalized, continuous care. That's why I introduced H.R. 3288, the Access to Prescription Digital Therapeutics Act, to provide coverage for these new health technologies that can help PTSD in veterans, and so much more. My colleague on the other side of the aisle, Mike Thompson, and I have been champions of this for the last few years. I've won awards for this, and we need to work in a bipartisan manner to continue to move this. This is not something that we should be politicizing. This is something we should work together on. Unfortunately, in this day and age, so many things are politicized, and the American people are sick of it, and I'm sure you all are as well. Mr. Zengilowski, I got close on that. I appreciate you educating us on the landscape surrounding technology-enabled care. And I'm going to run these two questions together. So can you tell us how these technology-enabled devices, especially those that can be used at home, affect patient adherence to treatment, and how does this affect our health outcomes?
Thank you for the question and excellent pronunciation of my last name. Thank you. So your two questions, how do these devices impact adherence to the treatment program for patients on a remote monitoring program? And Dr. Murphy made a point that I think is relevant to your question. So in addition to providing one or more devices to a patient, we are also monitoring the data coming back from those devices in real time. So my company employs approximately 150 licensed vocational nurses, nurse practitioners, registered nurses, and medical assistants. And so if we see a reading that's out of range, we are contacting the patient. We are discussing, first we start with, are they experiencing symptoms? If it's a hypertensive patient and we see an increase in blood pressure, we're asking, are they feeling lightheaded? Are they having neurological symptoms? And making a determination. Do they need to go to the emergency room right now, or is this an issue we can triage and address? Immediately after asking the questions around symptoms, we're talking about causes. So did you take your medication or not? And a colleague of mine on the Remote Monitoring Leadership Council, HealthSnap, they had a great example, patient that was struggling to take their medication, and what HealthSnap ultimately found out was the patient, an elderly patient, could not open their pill bottle and was struggling to open their pill bottle. And so the nurse contacted the pharmacy and got easy open pill bottles for this patient filled, so this patient could now actually take their medication. And so in addition to having the data, seeing the data, and the data encouraging the behaviors we want, both medication adherence but also lifestyle change adherence, the intervention of the clinical staff that work directly with these patients drives compliance with the treatment protocols.
Thank you. Mr. Phelps, myself being a business guy for over 35 years, I really appreciate your concern for your employees. There's nothing more important, contrary to what some on the other side of the aisle might say about business owners, that there's nothing more important about your business than the people who work in your business and work alongside you to make you successful and to help them become successful as well. Applaud your ideas about how you get health care and better health outcomes for your employees. As Mr. Kelly said, there's nothing more important to a business than making sure everybody has a part of the success. Could you talk to us about the barriers that you originally faced when you wanted to switch to this type of model that you expressed to us in your testimony?
Really, the only barriers are just your own willingness to be able to just dive in as an employer and spend the time and resources to make it happen. The problem is there's no incentive on the other side to do that. There's no incentive from the insurance companies to offer a program. Believe me, I've asked, hey, we're doing this really unique, interesting program, and the answer is usually, well, all you got to do is go on our website and click these buttons and you get $200 off your deductible. And to me, I just immediately knew that was not the way I was going to go. So it was just a motivation on that part. From a policy perspective, the only thing I could think that the tools are already out there in my estimation. HSAs, I think, are one of the most underutilized tools that we have, but there's so many restrictions on the way that monies in HSAs can be spent. These devices we're all talking about, why can't I use my HSA money to buy a Whoop or an Oura Ring? That would make a lot of sense to me, to be able to allow employees and participants to do that kind of thing. So I think the tools are already there. I don't know that we need anything new. I think we need to just recognize the tools we have, maybe ease some of the restrictions that we have on those types of pre-tax dollars that employees have access to. And maybe if the insurance companies could find a way to recognize that employers that are being innovative and creative and investing in the health of their employees might have an opportunity for some sort of relief on their premiums would be nice.
Thank you. Mr. Chairman, I yield back.
Mr. Davis, you're recognized.
Thank you, Mr. Chairman, and let me thank all of our witnesses. Let me just state from the offset that I am a strong supporter of telemedicine and telehealth. Both are very valuable and greatly used. When I read the title of this hearing, Health at Your Fingertips, Harnessing the Power of Digital Health Data, I couldn't help but remember a book titled 1984 by George Orwell, with a slogan in the book which said, "Big Brother is watching you." This phrase has become synonymous with the idea of excessive government surveillance of people. Collecting health data on people is always subject to questions about privacy rights with respect to knowing how the data is being used and what type of monitoring and tracking people will be subjected to. For example, the Department of Government Efficiency has been allowed to access federal data and share information without any explanations, guidelines, or oversight to Congress and the American people. And I'd also have to ask the question, how would people with no insurance afford to pay for digital health technologies? Professor Corlette, let me thank you for joining us and for sharing your expertise. I think we can agree, and I certainly believe, that healthcare is an investment in the quality of life for all people, and not just an expenditure that we look at and wonder whether or not we ought to be paying it. As Congress debates cutting more than $1.5 trillion in spending from our safety net programs, such as disproportionate share hospitals, federally qualified health centers, Medicaid, Medicare, changes to the Affordable Care Act, and providing premium health tax credits for those who purchase insurance through our marketplace, with 16 million Americans being purged. My question really becomes, how will these cuts and changes impact the health status of individuals who need these services? And what impact will they have on our overall economy as we look from both our own national perspective as well as globally?
Thank you for the question, Congressman Davis. So first of all, I just want to address this question of eligibility that has been raised and whether or not the bill would affect people who are eligible for health coverage programs. I'll just give one example. The state of Arkansas implemented work requirements in its Medicaid program. A study found that 27% of people lost their Medicaid coverage, despite survey data showing that only 4% were actually ineligible under the work requirement rules. That means that as many as 85% of the people who lost insurance coverage were actually eligible for that coverage. They just got tied up in the red tape that was required of them to prove their eligibility. So H.R. 1 does three primary things to take healthcare away from people. Number one, it makes people ineligible for the coverage, even though they are eligible. And this includes people who are legally present in this country and are hardworking, tax-paying people. Secondly, it increases the paperwork they have to go through to get that coverage, tying them up in a maze of red tape before they can access it. Thirdly, for people who are able to navigate that maze and maintain their insurance coverage, they have to face higher premiums and higher cost sharing to access healthcare services. So when people are facing these kinds of barriers, they don't get the care they need, they delay the care they need, they have worse health outcomes, they show up in the emergency room, which, as we've talked about today, is far more expensive than trying to prevent or ameliorate the condition on an ongoing basis, and that just raises costs for everyone.
Thank you very much, Mr. Chairman. I yield back.
Thank you. Mrs. Miller, if you're recognized.
Thank you, Chairman Buchanan and Ranking Member Doggett. And thank all of you all for being here today. The majority of my work in the healthcare space is really focused on ensuring a robust patient access to care, particularly for rural patients. In my district, many of the patients have to travel hours, like even 5 hours, to see a physician or a specialist. 70% of the people in West Virginia have at least one chronic disease. This leaves the vast majority of our patients in my state with some really tough decisions to make on how they can manage their health care. So many patients actually don't even seek it as much as they really need to because of transportation or the cost or inability to even take the day off from work. Wearable devices seem to me to be a very good solution to some of these problems. If a patient can have a device tracking their vitals, their glucose levels, or their heart rate on their wrist or even their finger, they can have some peace of mind about their health because they're very aware of it. And they also have a better picture of when it might be time for them to really go to the doctor. Dr. Holmes, I'm sure you've worked with many patients to help them get the most out of your company's technology. What are some of the benefits rural patients can see with wearable health devices? And are the patients able to see and share that data from your device with their physician?
Yes, we have mechanisms inside the app that allow for really easy sharing with your healthcare provider. I think one really good example is actually preterm pregnancy research we did with Dr. Sean Rowan at University of West Virginia Medical, where we were able to actually identify a digital biomarker that can basically diagnose or alert to potential preterm birth.
Like preeclampsia or something like that?
Yeah, well, so what's happening physiologically is 7 weeks prior to delivery, we were able to notice that there is a sharp increase in one of the metrics that we track, heart rate variability, and a sharp decrease in resting heart rate 7 weeks prior to delivery, regardless of gestational age. So you can imagine a woman in rural West Virginia who sees this inflection point and can then at least call a doctor and say, hey, what's going on here? So that was, I think, a really neat breakthrough. These data are published in PLOS ONE, and this, I think, was a great example of how we can help, in this case, women specifically, understand their bodies a bit better and use the data to get ahead of what could be a serious issue.
Wow, things have changed since the 1980s
I know,
when
right?
I had children. My constituents take their data privacy very seriously, and I think patients being able to share their data with their physician is important, but many of them are reluctant to simply give their data like to a device company. Mr. I'm going to mess this up, Zengilowski, I did it. What are some of the common misconceptions about data privacy with wearable technology, and how do remote patient monitoring companies, which facilitate the exchange of information from the device to the provider, ensure patient data is protected?
Thank you for the question. I appreciate it. And patient security, patient information security is paramount. So first, just to understand, there is a difference between a consumer wearable device and a device used, a medical-grade FDA-cleared device used in a remote patient monitoring program. We, CoachCare, sign business associate agreements with all of the practices and hospitals that we work with, which make us a covered entity under HIPAA regulations. So we are required to follow HIPAA. I will share with you, CPT code 99454 reimburses for the technology for remote patient monitoring, and the average Medicare reimbursement is approximately $45. We spend $10 per patient on security, on IT infrastructure security. So just to give you a sense of what we're investing to protect the patient data that we collect.
Okay, thank you. Another issue I take seriously is falls prevention and detection. In my state and country, people are rapidly aging, and unintentional falls are a leading cause of injury and death among seniors. Many seniors don't know that they're at a falls risk and can suffer a fall. So Dr. Holmes, do you think that wearable technology can help with this issue among seniors? And what types of technologies exist to track balance or falls or alert someone? Dr. Holmes. Dr. Holmes.
I'm so sorry. Can you repeat the question?
Oh, it's a long one.
Oh, I'm so sorry.
The technology, how
Yes.
can this help them know that they're going to be at risk for falling?
Yeah, I mean, I think this whole conversation really needs to go back to prevention. We need to help seniors understand earlier what is going to prevent a fall. You know, we need to get, I think the national conversation has to shift, right? A lot of the things that we're talking about are absolutely preventable. We just need Americans to understand that they need to lift heavy weights. And it sounds so simple, but everything that we're talking about here is democratically available and free. It doesn't cost a dime, right? You can do body squats. Americans just need to understand that they have the power to take control of their own health. And so I think we need to get that information out there.
Okay, thank you so much. I yield back.
Thank you, Mr. Chairman and the ranking member. Thank you all for being here today. According to CMS, approaching 60% of Americans have at least one chronic disease, and the rapid growth in wearables and access to remote patient monitoring services has been discussed robustly here, allows individuals to lead healthier lives with increased access to vital health information. Wearables and RPMs have been shown to improve treatment adherence for certain chronic diseases such as diabetes, and also better inform healthcare providers of their precise patients' needs. These are important advances in patient care and in creating healthcare savings. And as patients and providers utilizing digital data have improved chronic disease management. And as we all know, chronic diseases are a major, major cost driver in American healthcare. Dr. Gerhart, in your testimony, you shared that your patients have the ability to sync their wearable devices to their patient portal, MyChart, so their physicians can monitor their daily health data and their daily care. Can you share more about how this specific practice has improved patient care for your patients with chronic diseases, and also what are the main barriers that healthcare providers have in adopting the use of these digital tools?
Thank you, Congressman, for the question. So a great example of how this has been affecting chronic care is with prediabetes and diabetes, specifically in rural health areas, and frankly, anyone that is interested in understanding their health. You're able to get real-time information now that you can share with your clinician that actually helps you be able to understand if you're going to get a disease, perhaps even before you get it. So we have some early work that we recently started with Abbott, where we are able to, in working with them, have the continuous glucose monitoring data flow into the EHR, first as a PDF, but then also as multiple discrete pieces of information. And the idea there is not only can I monitor it and monitor trends, but also over time I can look at my population health, my family practice, and see how my population is doing with their diabetes.
Thank you. And to follow up on a separate question, Dr. Gerhart, I want to discuss patient privacy as it relates to these digital devices. Given how quick the development has been and changing in this field, obviously security is a major, major concern for patients across America, certainly in our district in Pennsylvania as well. Patient records have become increasingly more vulnerable. I think that's an obvious. Data we have suggests that close to 275 million American patient records have been compromised just last year alone. Given these recent developments in wearables and RPMs, obviously, if you could, expand on the role that HIPAA has within this conversation of digital health data, and what may be the best practices adopted to prevent bad actors, both here and abroad, from compromising health records to use for nefarious purposes?
Yes, thank you for the question. So it is confusing for patients what happens to their data, and we believe that HIPAA should be expanded to cover all entities exchanging patient health data. And to the cybersecurity and security question, we can look at both before something happens. So in Epic customers and our health systems, we are looking at what do we do if the system goes down? How can we run downtime? What does it look like to be on paper and so forth? And then also, if something is breached, what is the root cause of that breach, and how can we get to a place where most quickly patients and their providers can again access their health data?
And on that topic, Dr. Zengilowski, as someone who facilitates a transfer of patient data from devices to the providers, what resources have you devoted to privacy protections, and what have you seen as the best practices in preventing bad actors to access sensitive healthcare records?
Well, thank you for the question. And first, I do have two great regrets. One is I did not serve in the military, and I did not go to med school. I am not a physician. I'm not a doctor. Our investment in security is really around, so we exchange data with EHRs such as Epic, and so we are in possession of, we collect directly and also receive from EHRs patient data. And so we invest significantly in preventing those bad actors access to our system. That includes first, hiring some of the best and brightest in the engineering space, which is incredibly expensive, but it also includes going out and hiring outside parties to try to penetrate our system. We call them pen tests. We do them regularly. That's how we can determine, do we have vulnerabilities and how do we fix them?
Thank you all. I yield back, Mr. Chairman.
Mr. Evans, you're recognized.
Thank you, Mr. Chairman. Thank you, Ranking Member Doggett, for holding this hearing today. Technology can bring a lot of great opportunities for patients and providers in home-based hospital care. Using food as medicine and monitoring healthcare for health risk conditions like strokes. However, many Americans can only have access to these services through Medicare enrollment. For example, the Pennsylvania Council of Long Living provides telecare through Medicare home care-based services. Medicare provides elderly disabled Pennsylvanians with technology to monitor vital signs, to assist Medicare compliance, and even to notify emergency expense. Unfortunately, the Republican budget can take away this life-altering technology with billions of dollars in Medicare cuts. Americans should be able to benefit from new technology, so I continue to fight for Medicare. I would like to ask the question to Ms. Ms. Corlette. Give me a reaction to what I just said and what your thoughts are.
Yeah, certainly, and thank you, Congressman Evans. I think the concern that I have, and I think that many of us have, is that H.R. 1, the budget reconciliation bill, by slashing over $1 trillion in healthcare funds from the budget, it's going to result in 16 million people losing health insurance. It's going to result in people who are on health insurance programs, Medicaid, Medicare, and employer-sponsored insurance, facing increasing costs. And we know when people lack health insurance, they do not get needed healthcare services, particularly the primary and preventive care that will keep them healthy and part of the workforce. We also know that when they do ultimately get care, it's often too late, or the condition or disease that they have has gotten to such a point that it's very expensive to treat.
Any suggestions that you have relating to what you just said?
Well, my first suggestion would be to go back to the drawing board and try again on a different budget bill that doesn't result in millions of people losing their health insurance.
I'd like to go to Dr. there who talked about healthcare. Can you talk a little bit about, you talk about people having the ability to deal with their healthcare. You mentioned that a little bit earlier. I heard you say that. Yes, that's you.
Yeah. And sorry, what is your question?
You just asked the question. I heard you mention about individuals having the ability to deal with the health care. Can you speak a little bit to that issue? Would you say it?
Yeah, I mean, I think at the core, I think it's really about people understanding how to take control of their own individual health, understanding what are the levers and what are the metrics that you can track to help you understand if you're applying your effort in a way that is improving your health and reducing the chance of chronic disease. And I think my point earlier was that a lot of these behaviors are free. They are democratically available to all Americans. It's about helping Americans understand how to apply their effort. And I think that's where digital technologies have been so impactful, is that they understand, they cut through the noise and help people understand how it is they need to apply their effort with regard to sleep, with regard to circadian alignment, with regard to exercise and movement, right? Reducing stress, right? All of these things that are going to lead eventually to decline. So I guess my whole point is that digital technologies help us get upstream of all of this, right? It's going to help prevent falls. It's going to help prevent metabolic and cardiovascular disease, right? If we can help people understand how it is they need to apply their effort, and using digital health as a companion tool to support them.
I'd like to thank you, Mr. Chairman. Thank you.
Mr. Moore, you recognized.
Thank you, Mr. Chairman. Appreciate this conversation today on matters that are kind of happening now and important to the healthcare community. Mr. Zengilowski, as you may know, seniors wait on an average of 5 to 6 years from when the FDA authorizes a breakthrough technology until Medicare covers it. So the FDA authorizes it, and it's 5 to 6 years later till it's covered by Medicare. RPM devices like the one in your company's lineup don't require breakthrough designation, but they do need to be cleared by the FDA. Both Presidents Trump and Biden recognized the problem posed by needless delays in establishing Medicare coverage and addressed it through their respective MCIT and TCET policies. I'm actually hopeful that the administration chooses to return to its successful MCIT regulations. We live in really exciting times on the cusp of so many new health tech, data, wellness products coming to the market. Can you speak to what it would mean to patients to remove barriers to access to the latest products, especially regarding CMS coverage and reimbursement?
I sure can. I mean, in many cases, it's the difference between life and death. And when it's not, it's the difference between a high quality of life while managing one or multiple chronic conditions and a very low quality of life. One of the primary benefits to these technologies, the technologies you're discussing, patients can manage these conditions at home. And so what we see there are better outcomes and a better quality of life. Also, of course, lower cost.
Look, we're putting forward some legislation, and it's gone through iterations. My former colleague from Cincinnati area had led it before. This legislation is going to ensure that our most innovative and breakthrough devices have a clear roadmap to Medicare coverage so patients can reap the benefits sooner, and so we can encourage this kind of innovation. The delay between having these two organizations, FDA and Medicare, having such a massive delay, it makes no sense to folks back home. They just don't get it. 5 to 6 years. So I appreciate the Trump administration's MCIT policies, and we're hopeful that they're able to quickly advance and get back to that, and we're providing legislation that would help codify it. Dr. Holmes, thank you for being here. A couple weeks ago, I had an ECG performed in my office just down the hall by one of your company's devices. It's incredible to see the progress the market is making in bringing up these once costly procedures to the customer's literal fingertip or even wrist on the device. Whoop memberships and other wearable devices are eligible for reimbursement through health savings accounts, HSAs. The House passed several HSA provisions in our reconciliation process this last month, including expanding eligibility for HSAs to more groups of people, like seniors. Do you know what portion of your customers use HSAs to pay for memberships? Would you agree that expanding HSA accessibility could help more people take control of their health care?
I don't have the number, but there's no question that more accessibility to these type of technologies is only going to improve the health of American people. So, completely agree that more access, the better.
Yeah, I mean, I see it more ubiquitously in our daily life that people are taking advantage of these types of products. They're seeing value to it. They're monitoring their sleep. They're noticing that things that we've intuitively known for a long time, but you just really didn't pay a lot of attention to it, are now, literally at their fingertips. And if we're unwilling as legislators to recognize that there's an enormous cost to an unhealthy lifestyle.
Yeah.
And if we give up a little bit of cost to expanding HSAs to encourage people to live more healthy lifestyles, we're saving an enormous amount of money. Utah's a unique state. It's one of the largest penetrations of HSAs. I think uniquely Minnesota is another state. There's no reason for states not to recognize and individuals not to recognize the importance of this. It's all about reducing costs overall, and HSAs have been a uniquely important aspect. We've got a huge opportunity to help more people take control of their health care by expanding this HSA eligibility. I was disappointed to see that HSAs were excluded in the Senate's first draft of the reconciliation bill, and I'm working to ensure these provisions are included in the final version. And I yield back.
Ms. Tenney, you're recognized.
Thank you, Chairman Buchanan. I appreciate it. Thank you to our witnesses. This has been just a great topic. I have to echo the sentiment. As a owner of a small business, HSAs are terrific for us. We're hoping to advocate to get that added back in the Senate as well. Wonderful options for people to really control their health care, which I think is one of the big issues that we have now. And I know somebody was referring to earlier about the ability of patients to actually get, pill bottles opened and everything. And I do remember the day when I was very young and my mother used to say, can you open these bottles for me in these jars? Now I'm at that age. I'm one of those people that, where's my son to open the jars and bottles and containers for me? But I hate to admit that, but I'm heading in on Medicare. And to that, my district in upstate New York is rural, and we're in crisis with a lot of health care. We have a terrible state government, which is concerning, and their delivery of health care is confusing and unfair to patients in many ways. And almost 240,000 people in my district of less than 800,000 are on Medicare. So Medicare is hugely important. And that's why we think that what you guys are doing in this field, especially with my rural district and on dealing with, using AI to capture data. I mean, all these things are really important. And we really appreciate the technology, the rural nature. People can't get to the doctor. They need to have some kind of access to have a delivery of care. And, I love the idea. I know Mr. Phelps, I believe you mentioned, HSAs to be able to buy a loop and or a ring. I know this watch kind of controls my life. It tells me when to stand and tells me I'm not at my move goal yet. And, for sometimes it's annoying, but it probably does make me do more. And I think about taking the stairs instead of the elevator. So I think all these things are good personal devices to get people focused on their own health care and the importance of taking their own health care back. And I think that's a mission of the chairman, is trying to get everyone healthier. He's always got great, wonderful people coming to talk about health. And so I wanted to maybe give my first question to Dr. Gerhart. And Epic obviously is an industry leader in electronic health records. Can you just tell us real briefly what Epic is doing to ensure the true interoperability of these products, that patients can get the data that they need and get it without the barrier to the information sharing? How is that something that you deal with on this access point?
Yes, thank you for the question. Our customers and their patients have access to over 750 apps using Epic's publicly available.
Wait, that sounds like a lot of apps. I don't know if I can handle all that.
Last year, our customers used our software to respond to over 111 billion interoperability calls with third-party apps, so even more.
Oh, wow, that's incredible. So are you, I mean, obviously, I see the benefit. Do you think your patients are seeing the benefit in the ability to access these apps and being able to daily deal with their own personal health issues? And they're capable of doing that as well. Some patients may not have that same type of aptitude for it.
Yes, thank you for the question. Yes, absolutely. They are finding value from it, and so is the health system. We're able to manage population health at levels that we haven't been able to before.
And that's something I think doctors are also happy with this in rural areas. I've heard this from an anecdotal basis. You could say that from a maybe more empirical basis.
Yes, correct. Family physicians especially, we struggle to be able to provide care to large populations, so being able to have access to information and remote patient monitoring is very helpful.
So quickly, I'm running out of time, but let me see if I can do the Zengilowski. Perfect. Is that good? You mentioned in your testimony that CoachCare works with providers across the country. How has your company ensured that remote patient monitoring services are accessible to patients served by small rural hospitals or independent practices, especially not too many left in our area, but those that are left? In places like rural upstate New York, around the country, dealing with broadband gaps, we have workforce shortages, we have financial constraints. This stuff is really real. How does your product help us in that way?
Absolutely. It's a great question. And we work primarily with independently owned and operated family practitioners. One of the main challenges they face in delivering a service like remote patient monitoring or managing chronic conditions across a broad population is staffing shortages. It is very difficult to hire and retain NPs, RNs, MAs. And so that is a service we provide alongside the hardware and software to collect the data. We actually are that first line of defense, that triage. And so the physician really only has to focus on the 10% of patients that are struggling versus 100%.
And the real quick question, as I'm running out of time, how can Congress and the Centers for Medical, how can CMS help us? What can we do as an entity to help make this happen in Congress with laws or regulations?
To help the rural practitioners pass Representative Kustoff's bill, H.R. 3108, CMS encouraged them to stop the astounding and continued cuts to reimbursement rates for remote patient monitoring.
Great. Thanks so much. I yield back.
Thank you, Mr. Horster.
Thank you to Chairman Buchanan and to the ranking member. Good morning to our witnesses. We really appreciate your testimony, and while I'm all for digital health and data and these tools and technology driving people's opportunity to improve their health, I have to say that I feel like I'm a bit in the twilight zone because at the same time we're here talking about this issue, my colleagues on the other side just passed a bill that would effectively take away health care for 16 million Americans. People who are on the brink of losing their health care coverage, when premiums soar, when millions face crushing out-of-pocket costs, all because we want to give tax breaks to billionaires. The truth is, it doesn't matter how much cutting edge our health care technologies become if working families cannot afford to access them. We're very privileged here. We can talk about our devices, I've got mine, but that's not the majority of the folks that I'm here to represent, and I've got to make sure that their voices are heard as well. In fact, Ms. Corlette, you put it best in your testimony when you said that today's health care policy hearing is, quote, akin to Marie Antoinette telling the people of France to eat cake. This hearing feels like a distraction, an attempt to shift focus away from the devastating impact of the big, beautiful bill that's making its way through the Senate, which guts the healthcare system to fund tax cuts for billionaires. According to the Congressional Budget Office, if this bill is enacted as currently written, 16 million people will lose their health care insurance. This is in part because of the Medicaid cuts, the failure to extend the enhanced premium tax credits, and other attacks to the affordable care marketplace. The Urban Institute found that the one big beautiful bill will slash provider revenues by over $1 trillion in the next decade. In Nevada, total healthcare spending would drop by $4.4 billion alone. And as revenues drop, the cost of uncompensated care will explode, upwards of $283 billion nationwide, including $2.5 billion in Nevada. Last week, I hosted a roundtable with healthcare leaders from across my district to discuss these cuts and the impact that they would have on my constituents. Mr. Craig McCoy, the Chief Executive Officer of Centennial Hills Hospital, made a powerful point when he said that the biggest misconception of the big, beautiful bill is that people with private insurance think that it won't affect them. But the truth is, these cuts hurt them too. Cuts to Medicaid and the Affordable Care Act will increase uncompensated care, strain providers, and ultimately raise costs for everyone. The bottom line, hospitals will close in rural Nevada and rural America as well as in cities. Providers will shut down. Services will be scaled back. I have a rural community in Pahrump that does not have a birthing center and limited OBGYN services. So, Ms. Corlette, in your written testimony, you outlined the various impacts of the One Big Beautiful Bill on healthcare access and affordability. Can you outline for those who are listening the impact of the various healthcare cuts to the healthcare system at large, and what changes should patients expect?
Yeah, thank you for the question. And I think we've talked a fair amount about the numbers of people who are going to lose health insurance under this bill, but I want to thank you for also talking about what it will mean for healthcare providers and for the broader population that they serve. This bill reduces provider revenue by $1.03 trillion over the 10-year budget window. 40% of that decline is attributable to hospitals and 11% to physician services. Providers will also face a $278 billion increase in uncompensated care costs, and that doesn't even account for the Medicare sequestration that we talked about. When providers have a big increase in uncompensated care costs, they have to look for other ways to raise revenue. They're going to look to their commercially insured population. These are people with employer-sponsored insurance and other forms of commercial insurance. And they are going to demand higher reimbursement rates when they can, or they will consolidate, or they will close, or they will shut down service lines. Those are really the options. So it's higher costs for those of us with employer-sponsored insurance, and it means that particularly in rural and underserved areas, you're going to see reduced access to care.
Yeah. Mr. Kustoff, you're recognized.
Thank you, Mr. Chairman. Thank you for holding today's hearing, and thank you to the witnesses. Mr. Zengilowski, close enough, fair enough?
Close enough.
First of all, thank you for your testimony about my bill. I think your testimony's been brilliant all day, so thank you. If I could follow up on that bill, so the bill is the Rural Patient Monitoring Access Act. To your point, it's HR 3108. It is bipartisan. I can say it as a member of Congress, but if you could, in practical terms, can you talk about why the legislation is important and necessary?
I sure can, and it's not complicated. CMS adjusts reimbursement rates for the same services based on geographies. And so rural districts tend to receive fewer dollars for the same services from Medicare and Medicaid than, for example, a practitioner in San Francisco who may be paid 30 or 40% more than a practitioner in rural Nevada. In this case, the services that we provide, remote patient monitoring services, cost approximately the same wherever we deliver them. I mentioned before, we employ approximately 150 nurses, and they live in approximately 35 different states. We don't employ them in very high cost of living areas generally, and we provide the same technology to patients whether they're in New York City or whether they're in rural West Texas.
So if you're a physician in New York City, is it fair to say that he or she may be dissuaded from treating a patient in rural Idaho versus New York or San Francisco or Chicago?
I would say the issue is probably bigger than that. If you're a physician in rural Iowa or, like I said, West Texas, you're facing a decision right now of, do I even consider offering remote patient monitoring to my patients or not? Because where the adjusted rate is so low, it's a no margin service for independently owned and operated physicians. And so they're faced with a very difficult decision. Those practices cannot afford to subsidize healthcare for their patients. And so they're really fighting a difficult situation.
So you would encourage Republican and Democrat members to support this legislation?
Wholeheartedly.
Thank you very much. I appreciate your response. Dr. Gerhart, if I could with you, you mentioned in your testimony about the glucose monitoring devices, the CGM devices. There was an article in the past few weeks in the Wall Street Journal by one of their technology reporters. Here's the headline: "A glucose monitor for someone without diabetes, optimal or overkill?" Do you have any thoughts about people using glucose monitors who either may not be diabetic, may not be pre-diabetic, but want to keep up with their health?
Yes, thank you for the question. As a practicing family medicine physician, I focus very highly on preventive care. And one of the things that individuals can do the best to help prevent something from happening is by understanding their bodies and their data better. And so when it comes to continuous glucose monitoring, when patients use it, I want to see what they plan to do with the results. If they plan to take the results and bring it to one of their physicians to help them manage perhaps pre-diabetes, for example, then that's a win. Or if they bring it to, say, their grocer and they decide what they want to have for food or change their exercise, for example, again, that's a win. So really anything that's allowing change for behavior that will then prevent disease.
What if someone is not, the article talks about this, somebody's not pre-diabetic, but they're interested in when their blood sugar spikes because of certain foods they eat or certain times of day? Is that beneficial or is it overkill?
It's a good question. It's on the spectrum. On one end of the spectrum, people come in for medical care for diabetes, which is a diagnosable disease. And then on the other end of the spectrum, there is how are you going to live your life to the healthiest that you can and what empowers you to do so. And diabetes, pre-diabetes, or no diabetes, if that device allows you to help inform you and educate you as a patient to be able to better take care of yourself, then I think it's worth it.
Thank you very much. Mr. Chairman, I'll yield back.
Mr. Stube, you're recognized.
Thank you, Mr. Chairman. As someone who represents a large number of rural Floridians, veterans, and seniors, I recognize the importance of innovative tools that can improve health outcomes. If they are accessible, secure, and don't add new burdens. Digital health has great potential, but it won't mean much if it's out of reach for rural providers or puts patient privacy at risk. As we explore remote monitoring, AI, and wearable tech, we must ensure our small clinics and rural hospitals aren't left behind and that patient data is treated as sacred, not a commodity. Mr. Phelps, I'll start with you. What lessons would you share with other small businesses who are hesitant to adopt wellness or wearable initiatives?
Again, I just would go back to my earlier remarks that it's a vital conversation to have with your employees. If you want to find ways for them to not burn their time from being sick, but rather than use that time when they're scheduled to be on vacation or spending time with their families, then this is a conversation to have. If you want to make sure that when you're trying to meet deadlines for your production or deadlines for a new client or things like that, but your employees are out because they're sick or they're missing extra time, not feeling well, then it's a conversation worth having. The return on that investment, it's really hard to measure in real dollars, but it is very real and it's very critical. And it's another part of it is just building culture. You know, in our business, one of the neatest things about our whole initiative has been the conversations that we never would have had with our employees that we now are having. You're ribbing each other about what you packed for lunch or what you're bringing. Did you get your steps in today? Hey, we got a competition coming starting next month. In our marketplace, we got 4 businesses competing for a step contest, and we're already contacting each other through Facebook and everything else starting to give each other a hard time about how bad they're going to lose and how they're going to have to buy us lunch. So, I mean, it's just this whole different ecosystem is starting to come out of this whole program that I never expected. That is just something that never would have happened if we hadn't taken those first initial steps.
Thank you. Dr. Holmes, wearable tech is largely underused by seniors. I represent the largest senior district in the country. And in those rural areas, what can be done to improve adoption across those populations?
Yeah, my dad lives in Fort Pierce, Florida, and of course he has me to help him understand the power of monitoring data. But I think, a lot of it is just education and making these technologies feel less intimidating. So I think it's kind of boots on the ground, going to where the seniors are and holding sessions where we can educate seniors on how to use these technologies and how to think about the behaviors that we know are going to really move the needle with regard to their health. When we think about just the cumulative lifestyle exposures of things like alcohol, for example, right? If you want to increase the pace of your aging and make yourself more vulnerable, drink alcohol, right? There's a lot of simple things, again, that are free that our seniors can be adopting to improve their situation. So I think it starts with a national conversation that hits every single age demographic on the levers that we know are most powerful. And I will say that, folks on our platform, when we see decreases in alcohol by 89%, and that's not us shouting at our members, it's them seeing the impact alcohol has on their physiological data, on their sleep. My dad is he's drank wine his whole life, and now he has maybe a glass of wine a week, right? And that's not because anyone told him not to drink wine, but it's seeing the data has made all the difference in the world. So I think that's really the power, and I think we need to, as a country, normalize these conversations in our workplaces, with our families. That's how we're going to make change.
Thank you. Dr. Gerhart, many Florida providers, especially in rural and underserved areas, struggle with the costs and integration of electronic health records. What actions can the federal government take to help improve update of electronic health record software among smaller, struggling providers?
Thank you for the question. In small and rural health communities, one of the ways that Epic helps to challenge this is by creating a program called Community Connect. It's one of the ways that we can extend our software from one of the other customers to the community around us. And our key at Epic is to try to innovate to allow for our clinicians and our patients to be able to take the best care of their patients and the rest of their population. So the goal really that I'm here to talk about today is the innovations that Epic provides to the community.
My time is almost expired. I think I'm the last person on the dais, so I want to thank each of you for being here today, and thank you for your time. I yield back.
Ms. Sanchez.
Thank you, Mr. Chairman. It's no surprise, I think, that the Republicans are once again attempting to distract the American people while conveniently ignoring the 16 million people that are about to lose their health care coverage. And although we heard some misinformation on the other side about it's all illegals, the vast majority of the people that will lose their health insurance are eligible for that health insurance. Don't get me wrong, I appreciate this hearing because there are numerous benefits to tracking your physical activity level, your heart rate, your sleep patterns, and sharing that data with your doctor. But there's, the house is on fire and we're talking about holes in the window screens right now. Dr. Gerhart, I want to thank you for your testimony today. We've heard a lot about people's data and keeping it secure. You stated that we need policies to manage the risk of patients unknowingly losing control of their own data, especially to actors that are not covered under HIPAA. Who are some of the other actors that you referred to in your testimony, and what are they doing with that data?
Yes, thank you for the question. We've seen class action lawsuits from law firms accessing patient data, claiming to be physicians treating patients, but instead they're using data to recruit patients for lawsuits. Law firms are not covered by HIPAA, so there are no consequences to them. That's one example.
Are there others?
Yes, oftentimes patients are very confused about where their data go. And so as they look across the ecosystem, they will not know whether it's going to a HIPAA-defined entity or not unless that's disclosed by the specific app. So there are many others that aren't covered under HIPAA.
So there is the potential for many people to get this very private personal data from folks that are not subject to confidentiality. Thank you. As we know, Secretary Kennedy yesterday stated that he wants everybody wearing a wearable within 4 years. Mr. Chairman, I would like to submit a Financial Times article into the record with details the members of the Trump administration who have ties to the wearable business, many of whom coincidentally saw their stock shares jump up in price yesterday after Mr. Kennedy made those statements.
Without objection, so ordered.
Thank you. And I think, you know, if the government wants us all wearing wearables, we should all take note that both the CDC and HHS are integrating their data storage to Palantir's platform. Dr. Gerhart, is a company like Palantir covered under HIPAA?
Thank you for the question. Palantir may be operating under a business agreement that I'm not specifically aware of, but really the most egregious situation that we've seen so far are those class action lawsuits where law firms try to recruit potential
That
clients.
wasn't the question. My question was, is it subject to HIPAA? It's a business. Is it subject to HIPAA? Yes or no will do as an answer.
To my knowledge, HIPAA covers only HIPAA-defined entities, and what I know of Palantir, I don't know that they provide specific HIPAA-covered entities, but that's not my area of
I believe the answer is no. Thank you. It's very important that we protect patient data under federal law in the way that it is currently protected with any healthcare provider or health plan, so that businesses can't do an end run around that. On the innovation side, while wearable technologies can detect arrhythmias, monitor hypertension, and detect anxiety, I don't think that that data is really worth much if you don't have health insurance. How is a woman whose insurance coverage premium increases by $500 going to manage her endometriosis through fertility and menstrual cycle tracking, for example? Or how is someone who has kicked off their Medicaid coverage going to manage his diabetes solely by monitoring his glucose level or reaching his step goal if he has no access to insulin? I think it's innately ridiculous that while we are slashing health care for millions of people, we are talking about the health benefits of wearables. The expansion of the Affordable Care Act's premium tax credits reduced premiums for plans to $10 or less per month for 4 out of 5 people in the marketplace. Ms. Corlette, would failing to renew these tax credits and cutting Medicaid increase our uninsured rate? A simple yes or no answer will do.
Yes, it would.
Yes, it would. Thank you. And what effect does a higher uninsured rate have on our healthcare system in terms of costs?
Ultimately, it increases costs because these are folks who still need health care, but they'll wait to get healthcare services often until the disease condition is progressed to a state that it's very expensive to treat.
And if they go to, say, the emergency room because they've waited until they've gotten so sick and they don't have health insurance, who ends up paying for that care?
Taxpayers, commercially insured people, and hospitals and other providers that have to eat the uncompensated care costs.
Thank you. I appreciate all of you for being here, and I appreciate your testimony today. I yield back, Mr. Chairman.
Mr. Byer, you're recognized. Mr. Chairman, thank you very much. And thank you for staying. One of the great promises to me of the digital health data is reducing the rate of medical misdiagnosis. We have various bills out there addressing it, bipartisan bills that talk about 10,000 unnecessary deaths a year, maybe up to $10 billion in lost revenue. And everyone I know has a friend or a family member who's dealt with a delay in getting a diagnosis. I had a constituent case a month ago, a woman who'd been diagnosed with ALS and was preparing for the end of her life. And 6 months into the diagnosis, they ran different numbers and found out she actually didn't have ALS, and she's not going to die. The studies have found that something like 12 million Americans annually or have some kind of misdiagnosis. And so breakdowns in communication, coordinating care, other problems in the healthcare system. But at the end of the day, you can't get a diagnosis in the first place or apply digital health technologies to patient care if they can't get health care in the first place, which is the big concern we have right now about the bill that's in the Senate. Professor Corlette, the nonpartisan Congressional Budget Office found that the budget bill right now that we just passed in the House found that 16 million Americans roughly will be kicked off the health insurance. I talked to Frank Pallone, the ranking member on Energy and Commerce this morning. He said 8 million will lose it because of Medicaid, the new rules, another 8 million because the advanced tax premiums, the credits for the Affordable Care Act will go away. I've had every rural hospital in Virginia come to visit me saying their hospital is going to close. I do want to submit a record for the record, a letter from the Virginia Hospital Association talking about the devastating health cuts. But Professor, I'd love to know from your perspective, from academia, what's it going to mean for Americans if this goes through?
Thank you, Congressman Beyer, and as your constituent, it's great to be before you today. You're absolutely right. The Congressional Budget Office has projected that this bill, combined with the expiration of enhanced premium tax credits, will result in 16 million people, the vast majority of them eligible for health coverage programs, losing their health insurance. I think what is less talked about is how difficult it will be for people to maintain the health insurance that they do have because of the thicket of red tape that this bill creates for people to try to maintain their eligibility. It's that shoebox full of documents you're going to have to bring and upload and go through hours of red tape to try to maintain your coverage. It also increases the out-of-pocket costs that people have when they try to access healthcare services, whether that's through deductibles or other forms of cost sharing.
Yeah, thank you very much. And one of my favorite agencies is AHRQ, the Agency for Health Care Research and Quality, because they're the poster child for federal efficiency in government. And one of their examples of their work is hospital-acquired conditions, is eliminating the unnecessary and costly expense there. But unfortunately, this is one of the big targets of DOGE, and it got gutted. They riffed, apparently, many of the people of the Office of Chief Information Officer. They tried to outsource IT services, but then realized that they couldn't outcharge the people in charge of tech policy and cybersecurity. Dr. Gerhart, I turn to you in your testimony. You talk about interoperability. And AHRQ has long been one of the key agencies to help support and advance EHR adoption and the interoperability needs. Can you talk to why it's so important to have individuals in the administration who are experts at the interoperability piece?
Yes, thank you for the question. We at EPIC also consider ourselves experts in interoperability, and we find that interoperability, speaking as a family medicine physician, is key for me having all of the data that I need to be able to make the right information and the right decision on my patient. So it's critical that we have good interoperability.
And my family physicians keep retiring on me, and the whole notion of being able to carry those records forward and understand what happened 10 years ago and 25 years ago seems critical. But Professor Corlette, how might the federal workforce firings, the funding cuts, the hiring freeze affect our future workforce?
I think we're in the middle of a massive loss, a generation loss of public servants. And we talked earlier about the massive cuts to NIH and FDA are going to have a direct impact on some of the very innovative and exciting technologies that we're talking about because there won't be that bench research that gets us to this place, and there won't be the process, the speed to market with respect to FDA approvals.
Thank you very much. And Mr. Chairman, I yield back. Thank you. I want to thank everybody, but when I look at it, we're spending $5 trillion, and that number just goes like that, and we're getting sicker every year. We're 66 in the world. Our children at 20% obesity, used to be 3%. Can't serve in the service because 31% of the folks that would like to get in can't get in, they're obese. Seniors are, a lot of people are obese, 50% the population. I'm just looking at the raw data. we've got to start taking more responsibility. You got to encourage more people, if they can, to be CEO of their own life. It's not their problem. Many ways, it's everybody's problem. And as a community, we want to look after each other. I remember someone told me, stuck with me, that's why think about prevention, but he said that 50% of the people that have their first heart attack never see the next day. Now, whether that's right or wrong, I don't know, but he was very legitimate, said that number, and it just stuck in my mind. I don't like those odds. And, I know everybody's on yo-yo diets, I've been on them and all that, but I found a system 10, 15, 20 years ago, and it was a formula, and it made everything very simple for me. Be glad to give someone the book if they want to get it. But the bottom line is an equation. The top of the equation is nutritional food. How nutritional is the food you're about to eat? And it's nobody's problem. That's what I meant, because a lot of people do mean well, but a lot of the food we eat is garbage. It's over-processed. There's no value to it. And underneath the formula, it's calories. So the essence is make the choices. What is the most nutritional food with the fewest calories? And if you know what that is and you're able to make those choices, then you never have to worry about your weight or your health in many ways again. That's just my own philosophy. But let me close it out by saying I'd like to thank our witness for appearing before us today. Please be advised that members have 2 weeks to submit written questions to be answered later in writing. Those questions and your answers will be made part of the formal record today. With that, the subcommittee stands adjourned.